Now it is my pleasure to welcome and introduce our presenter, Dr. Kim Kelly, PharmD, BCPS, FCCP. He's going to discuss the association between obstructive sleep apnea and type 2 diabetes. Dr. Kelly is president of Kelly Diabetes Associates, LLC. He remains a faculty member of the Institute, and he's had more than 20 years of experience in diabetes care. Thank you, Dr. Kelly, and the floor is yours.
Thanks, Mary. As Mary said, we're going to be talking about the relationship between sleep apnea and type 2 diabetes, and quite honestly, it's a lot more complex than I thought when I first got interested in this topic. So we'll try to hit the high points during this program. But to start out, we're going to show you a brief video about what sleep apnea looks like. What you've just seen and heard is a sleep study where an individual who has sleep apnea stopped breathing. You saw and heard the fact that it took him almost 40 seconds to be able to start breathing again, and in the meantime, oxygen levels fell dramatically. We'll go through that in a little bit more detail as we go through the presentation, but that's what it looks like. So let's talk about obstructive sleep apnea. There are lots of different risk factors. High-risk patients, either the risk of sleep apnea or the risk from sleep apnea is involved in obesity, heart failure, nocturnal arrhythmias, bariatric surgery and the need for bariatric surgery, as well as type 2 diabetes and stroke. So we're going to talk about all of those during this presentation. Obstructive sleep apnea symptoms can be kind of divided into nighttime symptoms and daytime symptoms. The hallmark of nighttime symptoms is snoring. And snoring occurs pretty commonly. About half of the people sleeping actually have some snoring. All snoring is not obstructive sleep apnea, but most sleep apnea patients do have significant amount of snoring or loud snoring. If you have a partner that you sleep with, the observed apneas, choking, and so on, as well as restlessness during sleep is an important observation that your partner can make. Commonly, you'll see sweating during sleep. This is because of the autonomic nervous system response to the hypoxia. But in addition to that, some people grind their teeth, and there's also an association with decreased libido and impotence. During the day, because you have difficulty sleeping at night, there generally is some feeling of sleepiness and fatigue. We'll talk about that when we talk about screening mechanisms. But in addition to that, there's also associated poor concentration, decreased attention, forgetfulness. Those things tend to occur a little more commonly in aging, and also obstructive sleep apnea tends to be more common as you age. Obstructive sleep apnea has a whole variety of definitions. There are a number of organizations that have very detailed technical definitions. This is one definition that I like because it kind of fits with what we're talking about here. Obstructive sleep apnea is a breathing disorder during sleep in which a person frequently stops breathing during his or her sleep and has implications beyond disrupted sleep. That's what we're going to be talking about here, is what those implications are. Signs and symptoms we've already talked a little bit about. Loud snoring is, again, probably one of the most common things you will hear. Witnessed breathing interruptions, again, if you have someone who is available to witness. You'll also commonly find that these patients have obesity and or an enlarged neck size. In fact, that's even used as one of the screening criterion. And excessive daytime sleepiness, again, which is also used as a screening criterion. Other signs and symptoms that are not commonly associated with obstructive sleep apnea, but actually are common symptoms, increased blood pressure, headaches in the morning when waking up, some sexual dysfunction, and if you do an oropharyngeal exam, a crowded appearing pharyngeal airway. So what happens in obstructive sleep apnea? Here is a measurement of about 5 different things that you're tracking for an individual who has sleep apnea: the electrocardiogram, airflow, the thoracic effort, which is part of breathing, the abdominal effort, which is also part of breathing, and then at the bottom, the partial pressure of oxygen. Unfortunately, that's a little small to try and read. The numbers start at 98 on the left and go all the way down on the far right to 86. So during that episode that you're seeing between the 2 red lines, the individual significantly desaturated their blood from oxygen. They have hypoxic stress, and that stress is stimulating the brain to do everything it can to get some air in there and get the oxygen tension back up. So you'll see a gradual increase in the effort of breathing, and eventually the airway will open, and then there'll be a period of time where you breathe in, you oxygenate as best you can, and then hopefully you don't have any more of those. Unfortunately, when people have obstructive sleep apnea, they actually have them frequently during the night. The diagnosis of obstructive sleep apnea involves 2 phases. One is I guess the best term is pretest probability, the likelihood that you're going to find it. And that's an awareness issue. If you are thinking that people who have obesity are more likely to have it, you're right. If you think that people who have type 2 diabetes are more likely to have it, you're also right. And a variety of different things will increase or pique your interest. There are screening questionnaires, which we'll go through in detail. There's a sleep history, especially important if you have a partner who can kind of talk about snoring or talk about the restless activity during the night. Physical examination is important, looking at the oropharynx. If it looks crowded in the back of your throat, then the likelihood is it probably is, and that is more likely to result in obstruction, especially if you sleep on your back. There's objective testing, full-blown in-laboratory polysomnography. That's either full night or split night. We'll go through that, how that's done and why. And then home testing with a portable monitor, which is an up-and-coming way of actual diagnosing obstructive sleep apnea. So let's screen first for obstructive sleep apnea. Originally, years ago, it was talked about, this goes all the way back to the Dickens character in the Pickwick Papers, that was sleepy all the time. The idea here was that if you have intermittent arousals from sleep and never really get your full restorative REM sleep, then the likelihood is that you'll be sleepy during the day. This resulted in one of the earlier screening tests called the Epworth Sleepiness Scale. Essentially, the Epworth Sleepiness Scale talks about are you likely to fall asleep in a variety of different situations, and it was used originally to say if the answer to many of these is yes, then the likelihood exists that you should be further tested for sleep apnea. The Berlin questionnaire was the next on the block. It involves not only questions related to sleepiness, but also questions related to measurements of your neck, measurements of your weight, measurements, and as well as reported snoring. So there's a variety of different categories in the Berlin questionnaire. GASP is a relatively recent one. It's only a 4-question test that actually 2 of the questions relate to, did someone tell you you were snoring, and did someone tell you that you stopped breathing during that time? So it's not the best screening tool out there. The stop bang questionnaire is probably one of the more commonly used, and like the Berlin questionnaire, it also involves questions related to tiredness or sleepiness, questions related to snoring, and also some physical parameters that are associated with sleep apnea. So once you have screened and have a high possibility from the screening test, then you go to the diagnostic tests. The most important thing about screening tests is that they don't always result in a positive test. The idea here is that screening tests tend to miss about 1/3 of all the people who have obstructive sleep apnea, in some cases because they don't have a partner to make the observation and so on. But from the snoring standpoint, as somebody famous once said, we have an app for that. There now are snoring apps that you can put on your smartphone that will actually record you during the night, so you don't necessarily have to have a sleep partner. Your cell phone will do. Those are more recent. How effective they are and how useful they are is still under investigation, but at least now you have an objective way of recording whether you snored or whether you stopped breathing whenever you were sleeping. So the diagnostic tests for obstructive sleep apnea are, the gold standard is a test called polysomnography, and poly meaning a lot, somno meaning sleep, and graphy meaning lots of graphics. Outputs like you saw at the very beginning of this, in addition to the 5 that you saw on that initial slide, there are also, in a standard polysomnography test, there are 2 more leads that are electroencephalograms that measure whether you are actually sleeping or not. And then in a full-blown polysomnography test, there is an attendant that watches you during the overnight sleep. So a full polysomnography test is done in the Sleep Study Center. Unfortunately, there are not enough sleep study centers are out there to do tests for this, the presence of obstructive sleep apnea in the majority of people who have them. So that has led to the development of home sleep apnea testing, which we'll go over in a minute. The categorization of obstructive sleep apnea is something called the apnea-hypopnea index, the number of apneas where you stop breathing for at least 10 seconds, and the number of hypopneas where airflow decreases by at least 50% for a breath per hour of sleep. The criterion of no obstructive sleep apnea are an AHI of less than 5, mild is 5 to 15, moderate 15 to 30, and severe obstructive sleep apnea is an apnea-hypopnea index of greater than 30. Please note here that this is a frequency only. It doesn't talk about the duration of each of the apneas, and that can vary anywhere from 30 seconds all the way up to a minute. And in severe obstructive sleep apnea, oxygen tensions can go down in some cases as low as 70%. Over 24 manufacturers are out there making devices that you can use at home to test for sleep apnea. Home sleep testing is covered by Medicare since 2009, as well as other payers. And the reason for that should be pretty obvious, but the fundamental here is that obstructive sleep apnea is a major cardiovascular factor, and if you're able to find it with a home test, you probably should be testing more patients than you actually are. Home sleep testing is used as documentation of obstructive sleep apnea to show medical necessity for continuous positive airflow pressure devices, or CPAP.
All right, we have our first audience response question, and the question asks our attendees, what percentage of people with type 2 diabetes have obstructive sleep apnea? A, 1%, B, 5%, C, 30%, D, 50%, or E, 60%. And Kim, while our attendees are answering this question, we have a question from one of our attendees asking, how accurate AHI index are CPAP machines such as the ResMed S10? Hypopneas especially do not seem to correlate well with sleepyhead data and graphs.
Yeah, the hypopnea is an airflow measurement, and in some cases the airflow is flowing through the device but not necessarily into the patient. The accuracy of the apnea-hypopnea index on the devices that are present with CPAP are modest. They're not completely accurate for sure. To be honest with you, the apnea-hypopnea index is also not all that accurate in home studies, primarily because in some cases the patient wakes up, and while you are awake, you're usually not hypopneic or apneic. So what happens is the device averages in all those results, and it looks as though you have an AHI index which is lower than what actually occurred because the patient was awake part of the time. At home, it's very difficult to determine whether you're awake or not because normally the devices used at home don't have an electroencephalographic lead.
Great. Let's go ahead and close the poll and let you speak to the results, Kim.
Okay. Interestingly enough, whenever you're doing a multiple choice question, the answer is always the one in the middle. It isn't. Actually, it's the one at the end. The next slide, if I can close the poll here and go back to the slides. The next slide basically shows you a variety of different studies. There have probably been dozens of them. I just picked a few of them from the literature that show you the prevalence of OSA, and these are people with type 2 diabetes, which is the subject of this presentation. And you'll notice that the smallest total index is around 60%. In fact, in several studies, the prevalence of OSA has been as high as 86% of individuals with type 2 diabetes. This is the study by Hannes that you saw there in a population that was primarily Mexican-American. So clearly, obstructive sleep apnea is a lot more common than most people think. And those red bars are the total of total sleep apnea percentages in those studies. If you look as you go down, there's mild, moderate, and severe sleep apnea. And still, severe sleep apnea is present in roughly a third of the individuals who actually have obstructive sleep apnea. This slide talks about obstructive sleep apnea associated with morbid obesity, very obesity with a BMI generally over 40. A couple of things. In the left-hand panel, the dark bars are women, females. The far left bar is the percentage of individuals who don't have sleep apnea. If you do the subtraction, that is the majority of people actually have sleep apnea. The light bars are men. The dark bars are women. You can see that in women with sleep apnea, the more severe sleep apnea is relatively less frequent. For men with sleep apnea, the more severe sleep apnea is relatively more frequent. So there is definitely a difference, especially in the severity of sleep apnea between men and women, with men having roughly double the incidence. On the right-hand panel, it's an interesting discussion related to the relationship between age and changes in female hormones. But the bottom line is premenopausal women are in the left-hand light column. The dark columns are postmenopausal women. And you can see if with men in the far right three bars, their prevalence of obstructive sleep apnea between postmenopausal women and men in general tend to be relatively the same. So there is a relationship between age. The severity, however, is still always higher in men than it is in women. Kids are not left out of this either. Childhood obesity is associated with obstructive sleep apnea. There are about 4 studies that are presented here if you're looking at the total percentage of sleep apnea. And again, those percentages are roughly the same as you see in adults. Obviously, they're not quite as high, but sleep apnea definitely occurs in childhood. And also in kids, there is a little more prevalence of changes in oropharyngeal patency. So kids who still have their tonsils and adenoids, or some change in Down syndrome, for example, is associated with an increase in thickness in the neck and oropharyngeal pathway. So the bottom line is there's a slightly different predisposition set for childhood obesity and obstructive sleep apnea, but the incidence is still out there, and obesity is still a very common risk factor. So why is sleep apnea? Why is obstructive sleep apnea important? This is one of my very favorite slides if you take nothing away from this presentation. Unfortunately, obstructive sleep apnea remains the elephant in the cardiovascular room and often is ignored even in high-risk patients. In one study where 86% of people with type 2 diabetes were found to have obstructive sleep apnea of some degree, less than 1%, or pardon me, less than 5% actually were on treatment a year later. So clearly, recognition of obstructive sleep apnea is only part of the plan. Being on treatment to ameliorate the effects of it, ameliorate the effects of cardiovascular risk as well.
Thank you, Kim. Our next polling question asks, which of the following statements is true? The incidence of OSA is roughly the same in men and women. B, daytime sleepiness is the hallmark of OSA. C, diabetes causes OSA. Or D, OSA causes hypertension. And while our attendees are answering, we do have a question, and it asks, once someone gets their CPAP machine, if their number of events per night is low, do they require any sleep clinic follow-up?
That really depends on the physician. The question really is, and again, we're talking about the number of incidents, number of apneas or the number of hypopneas, but also the duration is something that's not figured in very well. If you have a very low number, but you have an apnea for a minute, then it's a big deal because your oxygen tension goes down dramatically. So in general, all patients on CPAP should be followed up in a sleep clinic or with a sleep medicine trained physician. There are a number of different certificate programs for family practitioners, primary care physicians, and of course, obviously, they're board certified sleep medicine physicians as well. But at this point, follow-up is important. If for no other reason than motivation of the patient by showing them the benefits of CPAP, which we'll talk about in a minute.
Great. Let's go ahead and close the poll, and we'll let you speak to the results, please.
Okay. Well, we've already talked about the incidence being different in men and women, nearly twice as often in men than women. Daytime sleepiness is, interestingly enough, originally thought to be the hallmark of obstructive sleep apnea, but actually only occurs in about a third of patients who have OSA. And this is one of the reasons why the Epworth sleep scale really didn't catch as many people with OSA as we would like. There is controversy related to diabetes causing OSA. We'll talk about that in more detail. But one thing we do know for sure is that obstructive sleep apnea causes hypertension. So let's talk about the metabolic consequences of obstructive sleep apnea. First and foremost, since we're talking about type 2 diabetes, glucose intolerance and obstructive sleep apnea do tend to go together. And there's always been a discussion, does obstructive sleep apnea cause diabetes? Does diabetes cause you to have obstructive sleep apnea? So what we're going to do is investigate that question. Sleep-disordered breathing and glucose are intertwined for sure. In this particular study, about 2,600 people without known diabetes who were in a sleep health study had obstructive sleep apnea measurements, a polysomnography test. 1,000 of them who were overweight had obstructive sleep apnea, and about 200 of them who were not overweight also had obstructive sleep apnea. So it is not the sine qua non that you must be obese in order to have OSA, but it certainly predisposes. In those individuals who had OSA, impaired glucose tolerance, impaired fasting glucose, and impaired a combination of both, as well as occult diabetes. In other words, they were not known to have diabetes, but once they were given an OGTT, turns out they actually did have diabetes and no one knew it, which goes along with the fact that many people with type 2 diabetes have it but don't know it. OSA severity is also related to how good a control you have in type 2 diabetes. In this particular study, they categorized the obstructive sleep apnea as none, mild, moderate, and severe, and subdivided the individuals based on those categorizations. And if you look at the average A1C of individuals who had severe OSA, significantly higher, obviously, than even people who had mild obstructive sleep apnea. So the worse the condition, the worse the severity of OSA, the higher your A1C is likely to be. In a meta-analysis of obstructive sleep apnea that was presented at ADA in 2012, a gentleman did a massive literature search and identified many articles related to OSA and diabetes, and a pooled analysis looked at the risk of developing diabetes if you had OSA and the risk of developing OSA if you had diabetes. And what they found was the presence of obstructive sleep apnea is associated with a dramatic increase in the risk of diabetes, but diabetes itself was not associated with increased future risk of obstructive sleep apnea. So yes, obstructive sleep apnea causes diabetes or certainly makes the condition worse. Whether diabetes itself is associated with future risk of OSA, the author concluded in his wonderful evaluation, these results suggest that OSA causes incident diabetes, but that the reverse is not true. In addition, OSA changes a number of facets of your chemistry to the point where you get increased appetite, and this is primarily because of a change in hormone levels. Daytime profiles of plasma leptin, ghrelin, and hunger and appetite on a questionnaire were studied in individuals who are in good health with only a couple of days of sleep restriction, which is what you would see when you have obstructive sleep apnea and have arousals during the night. The sleep restriction results, the satiety hormone leptin was decreased, the hunger hormone, ghrelin, was increased, and the hunger and appetite on the questionnaire was also significantly increased. So it looks as though obstructive sleep apnea increases appetite, and that may well predispose to yet increasing body weight over time. In addition, in a number of studies, measures of vascular damage were measured. In this particular study, they looked at VEGF, vascular endothelial growth factor. We know that that's associated with a variety of conditions related to the vasculature. Among them is kidney disease and retinopathy. And they found that there was a 2- to 4-fold increase in the risk of retinopathy and significant increases in albuminuria and the presence of chronic kidney disease as well. So there is damage to the vascular system that is mirrored in a variety of different factors that are released, VEGF being one of them, and that damage to the vascular system accumulates over time. There is a vicious cycle that's initiated by hypoxia. Once the O2 levels go down, and you'll see that at the top of this, as the O2 levels go down, the baroreceptors in the carotid arteries are stimulated. You can see the carotid arteries here in red. Once the baroreceptors are stimulated, what the brain is basically saying is, I'm not getting enough oxygen. I'm working to have you breathe more, but in the meantime, I'm going to try and increase flow by making the baroreceptors fire and increase sympathetic nerve activity, therefore increasing blood flow. However, if this happens frequently, like severe obstructive sleep apnea, what happens is the increase in sympathetic nervous system activity eventually generates hypertension. Hypertension, increasing vascular resistance, also generates potentially congestive heart failure. Congestive heart failure can also result in decreased blood flow as well. So it's a kind of a vicious circle here. What we do know is that decrease in oxygen tension increases sympathetic nerve activity and increases blood pressure, and eventually increases the load on the left ventricle, leading to congestive heart failure. In addition, there is a subset of vascular activity that's important, and that's so-called wake-up stroke or transient ischemic attack. This occurs most commonly when patients have long obstructions with significant hypoxia. Remember, I said in some cases the oxygen tension goes all the way down to 70, and the potential of right to left shunting occurs in a subset of patients. And as a result, the hypercoagulability of the blood due to diabetes as well as obstructive sleep apnea or hypoxia generates the formation of clots, and that clot in a right to left shunt may be essentially thrown to the brain, causing a stroke, so that the patient wakes up with either a stroke or a transient ischemic attack. In addition to that, hypoxia is not a friend of your heart when it comes to arrhythmias. Here is a fascinating study where you look at the relationship between obstructive sleep apnea and ventricular arrhythmias during the nighttime on the right, and also during the daytime. We have the thought that, yes, when there is hypoxia at night, you're bound to have potentially more ventricular premature contractions or complex ventricular ectopy. But interestingly enough, in people who have obstructive sleep apnea, it isn't just the nighttime where you see that. In fact, it seems in many patients that it's even more common during the daytime, potentially because of the strain on the heart from hypertension and some others. But the bottom line is, whether it's day or night, you have an increase in ventricular ectopic arrhythmias, which at the end of the day are definitely not good. Long-term cardiovascular outcomes in men with obstructive sleep apnea are not particularly good. If you look at non-fatal cardiac events as well as cardiovascular death, in those who are untreated with severe obstructive sleep apnea, that's the two bars in from the right, you'll see dramatic increases in non-fatal cardiovascular events as well as an increase in cardiovascular death, 287% increase in the risk of fatal and non-fatal coronary events compared to individuals who do not have obstructive sleep apnea. So what are the treatment options? The treatment of obstructive sleep apnea, there are probably a gazillion different things that people have tried. The most common is oral appliances. They call them mandibular repositioning appliances. You've seen ads for them on TV. The ads are essentially, if you have snoring, you can get one of these, you can put it in your mouth, and the bottom line is you'll not snore and live happily ever after. Whether these work in severe obstructive sleep apnea is definitely problematic. They seem not to. There's not a general agreement that oral appliances have much of an effect other than decreasing simple snoring or potentially decreasing mild obstructive sleep apnea. There are tongue retaining devices. There are a variety of different oral things that you can do appliance-wise to keep the tongue and soft palate from the back of the throat. The treatment of choice for all degrees of obstructive sleep apnea is positive airway pressure. Positive airway pressure originally was a continuous stream at a continuous pressure. It made many patients uncomfortable, so adherence to CPAP was a bit problematic with the earlier devices. Later on, bilevel, continuous airway pressure, higher pressure when you breathe in, and then lower pressure allow you to breathe out. And then finally, most recently, auto-titrating or APAP, where the system senses the pressure it needs to help you keep your airway open, but it doesn't give you any more than that. And it also senses when you're breathing out and reduces the pressure outward as well. APAP is clearly the treatment of choice for most patients, and most of the modern APAP or auto-titrating devices are awful quiet to use. It used to be the old-fashioned CPAP devices were loud enough that they would keep you awake in most instances. If it wasn't for the constant air blowing in your head, it was also for the device itself. But nowadays, they're quite silent, and they're quite a bit more comfortable than the original CPAP devices. There is a very unusual procedure where the hypoglossal nerve can be stimulated. While there is a device out there that does that, not very many people use it. Nasal appliances, there's a little valve-like device that you can put over the openings of your nose. They will let air in, but whenever you try to breathe out, they regulate the outward movement of air, so you're having a kind of an endogenous positive airway pressure. And finally, surgical treatments. There are lots of different surgical treatments, and we're going to go to a polling question and find out about them.
Thank you. Our next question asks, which of the following are not surgical treatment for OSA? A, laser-assisted thyroidectomy. B, adenotonsillectomy. C, uvulopalato-phalangioplasty, that's a tough one, tracheostomy, or bariatric surgery. And while you, the attendees are answering that, I will encourage them to ask some more questions, and we do have one question which asks your opinion, Kim, on which OSA questionnaire you recommend.
At this point, it's a toss-up. There are a bunch of studies that have validated and recommend the Berlin questionnaire. There are a number of studies that have validated and recommend the Stop-Bang questionnaire. If you go to the Johnson & Johnson Diabetes Institute website and up at the top look at resources, if you click there, you can actually get a copy of the Stop-Bang questionnaire. That one is used more commonly. So that would be the one I'd recommend, but they do have, do measure slightly different things. And so if you have one that's borderline, then you might want to try the other one. I don't recommend the GASP, and at this point, because of the fact that very smaller percentage of people have daytime sleepiness, I would not use the Epworth as often as I'd use the Stop-Bang questionnaire.
Wonderful. Let's go ahead and close the poll and let Kim speak to it, please.
All right. This is a fun one. I put the uvulopalato-phalangioplasty in there just to see if Mary could pronounce it. But the bottom line is all of these are working, let's see, the middle three, adenoid tonsillectomy, uvulopalato-phalangioplasty, I have a terrible time saying it as well, and tracheostomy, all of them tend to work on the breathing apparatus. Laser-assisted thyroidectomy does not. So you can remove the thyroid without interfering with the breathing apparatus. So that the answer is A. Bariatric surgery clearly is a surgical approach, and we're going to talk about that in a little bit. But bariatric surgery is very effective in mitigating type 2 diabetes. It also, depending on the amount of weight you lose, is effective in mitigating the obesity component of obstructive sleep apnea. We talked about continuous airways pressure. One of the bigger issues relating to CPAP that many of you are probably familiar with is adherence. It's uncomfortable in many cases to have delivery via a nasal airway alone, although you can increase the comfort by humidification and warming the air. But the fundamental is all of these have some form of discomfort because people are not used to sleeping with a mask or a hose attached to their face is the bottom line. Mask discomfort is probably the major reason why most people discontinue using CPAP. And there is a subset of people who, when they discover that they are in need of CPAP and told that they should be starting that, actually just decide not to do it altogether. But mask discomfort tends to be the most common issue associated with CPAP adherence. There are ENT and positional approaches, so we don't want to leave those out. If you look at the top picture there, there's a positional device that you wear around your belly and chest that has a chunk in the back that keeps you from rolling over on your back. Obstructive sleep apnea patients, if they sleep on their side, tend to be much less likely to obstruct their airway. So there are some patients who would benefit from a device like that. For others, surgery, especially if the oropharyngeal area is, I guess the best phrase would be crowded, an excess of tissue, big tonsils, enlarged soft palate, and so on, adenotonsillectomy, as well as removal of the uvula and so on, are ways of cutting down the obstruction by kind of doing a roto-rooter type procedure on the oropharyngeal cavity, allowing better airflow. So there are surgical approaches. Tonsillectomy in adults is an awful procedure, very difficult for patients, and so as a result, these oropharyngeal surgical approaches tend to be more common in younger patients. CPAP adherence, the real key to the benefits of CPAP. There is a great review, 82 studies spanning over 20 years of CPAP use. Originally, when CPAP was first developed, it was one continuous pressure. And as a result, a lot of patients were uncomfortable with it. And so over time, about half of patients stopped using it within the first couple of months. Over time, with improvements in CPAP, like so-called BiPAP or APAP, there's been a kind of a leveling out at around 30% of people who simply do not adhere to positive airways pressure no matter what the device. In addition, adherence is not simply putting on the mask. Adherence is putting on the mask and using it for a period of time during sleep. And we're going to talk about that in a little bit more detail. Putting it all together, obstructive sleep apnea and obesity at the top generate oxidative stress. Those issues relate to high blood pressure, sympathetic activity. Dyslipidemia is made worse, interestingly enough, in oxidative stress, all impinging and causing inflammation, which many of you know reverts to cardiovascular morbidity and mortality. CPAP has a great effect on blood pressure since obstructive sleep apnea causes hypertension. Here is a great study looking at the decreases in blood pressure with CPAP. They are maintained over time. This is a 6-month study, and the initial CPAP result was a significant decrease in systolic and diastolic blood pressure, and that decrease was maintained over 6 months with both systolic and diastolic blood pressure. So there is a beneficial effect on blood pressure, and it's a major reason why patients, especially with moderate to severe obstructive sleep apnea, should be on CPAP. CPAP also improves cardiac functioning. Here are two panels. The top panel looks at the strain on the ventricle. The gray bars are essentially strain depending upon your apnea-hypopnea index. All the way to the right, you see the gray bar at the highest. That's an AHI of greater than 30. And if you look next to them at the red bars, you'll see the effect of CPAP. Once CPAP is administered, it looks as though even in severe obstructive sleep apnea, that the effect is mitigated by the presence of CPAP. So the strain on the ventricle is not nearly as much, statistically significantly different. In addition to that, at the bottom panel, you'll see left ventricular ejection fraction. Again, left ventricular ejection fraction in the light gray bars goes down as the apnea-hypopnea index goes up. So in essence, as you get more severe obstructive sleep apnea, you have lower cardiac output, left ventricular ejection fraction. But again, if you look at the darker gray bar, you'll see that that's pretty much mitigated whenever you have patients on CPAP. So not only is blood pressure lowered, but the strain on the heart and the ejection fraction of the heart are also the beneficiaries of CPAP in a significant way. Mortality with no treatment by apnea-hypopnea index versus individuals. We're going to not talk about individuals who are treated currently, but if you look at the different lines here in this graphic, the top line is individuals who don't have obstructive sleep apnea. The bottom red and bluish lines are individuals who have moderate to severe obstructive sleep apnea. The survival is around 85% over 10 years in individuals without obstructive sleep apnea. When they have moderate to severe, it goes all the way down to in the neighborhood of around 70%. So the mortality is actually doubled, apparently, for individuals when they have moderate to severe apnea-hypopnea index or moderate to severe obstructive sleep apnea. So the outcomes of treatment with obstructive sleep apnea, first of all, if you do have daytime drowsiness, especially if that daytime drowsiness affects your job, as you saw at the very earliest in the video, the individual who had the obstruction that you saw in that video was an individual who worked on heavy machinery or dangerous machinery. Individuals who are over-the-road truckers, places where drowsiness makes a heck of a difference. Those are the things that you really need to be careful of and need to be treating as early as possible to cut down on the likelihood that someone falls asleep at the wheel or someone falls asleep in a dangerous situation. If you have a partner that you sleep with, patient and partner satisfaction is very important. Oftentimes, if one or the other partners snores loudly, you'll often see them separate either into different rooms or certainly into different beds. So improvement of patient and partner satisfaction is paramount here. Adherence to interventions is an interesting one. One of the outcomes of the treatment with CPAP is better adherence to CPAP. I know that sounds funny, but if you have moderate to severe obstructive sleep apnea, very moderate to severe AHIs, you perceive a significant benefit in terms of your blood pressure going down, your comfort breathing and sleeping, and so on. So for people who have significant obstructive sleep apnea, what you'll find is that they're more likely to stick with it than individuals who are not seeing any benefit to CPAP. There's a decrease in avoidance of risk factors. The risk factors include those associated with hypoxia, such as hypercoagulability, hyperlipidemia, strain on the heart, and so on that we've already talked about. And when it makes a difference, and it does to pretty much everybody, you obtain an adequate amount of sleep. For those times when you have an obstruction, generally that obstruction is associated with what's called a microarousal. You don't actually waken, but you don't continue in the sleep pattern down into REM sleep, which is the so-called restorative sleep portion of your night's sleep. By cutting down on the apnea-hypopnea index with CPAP and other treatments, oftentimes patients are able to go down into REM sleep and have a much more restful sleep and feel better when they wake up. Also associated with CPAP is a weight loss. It's not staggering, but weight loss has been associated in many cases as a treatment. And finally, as you saw in the last slide related to mortality, they likely live longer as well, which is a benefit that needs to be explained to every patient as you're talking about sleep studies. So the question that I'm going to leave you with is next week, many of you will see a number of diabetes patients. I'll make the guess of around 10. Let's say you see 10 patients next week who have type 2 diabetes. Nearly all will have obesity, and about 6 or 7 of them will have obstructive sleep apnea. My question to you is, which ones? Do you know? Do you use a screening questionnaire? This is a really important part of OSA treatment is what's called the pretest probability. What is your index of suspicion that this person may well have obstructive sleep apnea? Because if you can get them tested, if you can diagnose sleep apnea, and if you can help them to get on to CPAP, they will definitely have a benefit in a whole variety of cardiovascular risk factors, not to mention the fact that they may well live longer. So with that, I'll say thank you and entertain any questions.
Wonderful. Thank you so much. And we do have time for a couple of questions. So, Kim, the first question asks, they want you to explain again the differences between APAP, BPAP, and CPAP devices.
Okay. The CPAPs were the earliest devices, and they essentially pumped air under a continuous pressure that was singular. That is, it only had a positive pressure all the time. And so as a result, it didn't adjust from a comfort standpoint. It had to be titrated. Usually you had an individual, a respiratory therapist, who helped you to tune into the right pressure. But the bottom line is, in some cases it was comfortable, in other cases it was not, or something that was comfortable was not on certain days. So that's what led to a lot of individuals to be uncomfortable with the original CPAP. The next generation of devices actually had 2 different pressures, one to keep the airway open, and 2 to cut down on the pressure so it made exhalation easier, and that was called BiPAP. There are a number of BiPAP devices out there and a number of manufacturers that make them. But even that, the pressures tend to change over time. The individual tends to change over time so that not the original settings of where the higher pressure and the lower pressure were set are universal and remain the same all the time. The advent of the auto-titrating positive airway pressure is moved into a significant comfort zone here, that the device senses when you're breathing in, senses how much pressure is necessary and on breathing in and breathing out, and as a result titrates itself almost on a breath-by-breath basis. This has led to a significant increase in comfort for patients who have the diagnosis of OSA nowadays. Most patients prefer or would like to get the auto-titrating positive airway pressure, although obviously if it has more benefits, it's more expensive as well.
Wonderful. Next question asks, how does a physician determine optimal CPAP settings and when/how do they need changes?
The settings are determined usually whenever you do polysomnography, especially if you do it in a sleep lab. The individual who is there, they'll do what they call a split night study. They'll find the apnea-hypopnea index for a certain number of hours, and then they will put a CPAP device on the patient and continue to measure the apnea-hypopnea index as they adjust the pressure upward. The individual who's doing that is generally a trained technician, although a trained and certified physician can do the same thing. How often those things change really relate to a whole variety of things, and everything from if you lose weight to what the percentage of pressure is changed over time. The bottom line is that it is highly inter-individual. Having a physician who is trained in sleep medicine will help, but it may take several different adjustments over time because patients do change.
Thank you. Next question. The heart muscle seems to be affected. Does sleep apnea also affect the electrical conduction system of the heart?
The answer is yes, to some extent. There are changes not only in ventricular dysrhythmias, ectopic arrhythmias, but also there is a modest effect on the conduction system. Obviously, they are fully integrated, so the conduction system itself, in some cases, is the source for the ventricular ectopy. But do patients who have this have dramatic increases in atrial fibrillation? Do they have increases in heart block or other kinds of things? It seems as though that's not the case. Ventricular ectopy can be generally related to the muscle itself, or can be related to the Purkinje system in the conduction system in the ventricle.
Wonderful. And Kim, thank you so much